everyone. Thank you for coming tonight to the first of our Marina Del Rey Hospital Women's MISSY seminars. MISSY stands for the Minimally Invasive Surgery Institute, and we started the program to meet what we felt was an unmet need within the patient population of Los Angeles to provide cutting-edge health services for the women in the area, particularly using the best technology, the best techniques, and working with the best surgeons. When we decided that we were going to launch this program, we knew that we wanted to work with Dr. David Goslin. We've been working with Dr. Goslin for a little over 2 years, and we know him to not only be a fantastic surgeon and clinician, but also to be a true champion for women's health care and really an empathetic and effective doctor. So I'd like to introduce Dr. Goslin, who's going to be talking about the program and some of the techniques he used.
Thank you, Nick, for the introduction. So I'd like to welcome everybody to our first MISSY Symposium. Like Nick said, I'm very proud to be associated with Marina Del Rey Hospital and the MISSY Institute. What we thrive for as surgeons, and why I decided to pair up with the Marina Del Rey Hospital, is to really take women's minimally invasive surgery to the very forefront of its capabilities and push the boundaries beyond what we can do currently. One of the things that I'm very proud to say that here at Marina Del Rey 2 weeks ago, we performed the very first single incision, nearly scarless hysterectomy in the greater Los Angeles area with much success. And because of this, we could really establish ourselves as one of the pioneering hospitals, with some of the pioneering surgeons, in helping women and helping them empower themselves by recovering faster and almost having no scars. My presentation tonight is really for the patients. I'm here to talk about some of the most common benign conditions that present and how we treat them both surgically and non-surgically, and introduce you guys to the world of robotic surgery. So with that, I'm going to go ahead and take the next slide. So we're here today, like I said, to talk about the health issues that affect women in our society and learn about the potential benefits of what a virtually scarless approach to surgery can do for patients, as well as some of the potential benefits and risks of surgery, and some of the questions that you can ask your own physician as a take-home message from our presentation. Next slide. Tonight we're going to talk about some of the most common benign conditions, such as abnormal uterine bleeding, fibroids, endometriosis, pelvic pain, ovarian cysts, and pelvic organ prolapse. Before I start, I felt it would be important to sort of generally go over the female reproductive anatomy and talk about some of the areas that affect us. When we're talking about the uterus, we're talking about this entire region. And the uterus is composed of 3 different layers, both the inside, the wall of the uterus, and the serosal layer, which is on the outside. And we often find that can be affected with adenomyosis and fibroids, which I'll be discussing later. The fallopian tubes and the ovaries, which sometimes present with cyst and pelvic pain, as well as the cervix and the vagina. So all of these, let's back up one more time. We see that all of the conditions are simply affected in these little tiny organs, and I find that fascinating. Go ahead and move forward, please. When we talk about abnormal uterine bleeding, we have to define it in order to properly present it. It can have different pathologies. You can have anatomical reasons for abnormal bleeding, such as fibroids, polyps, adenomyosis, which is a form of endometriosis, as well as endometrial cancers. All of these can lead to abnormal bleeding. And most commonly, we find that abnormal bleeding is secondary to hormone imbalance, usually correlated between the estrogen and progesterone levels of women, especially as they change in their perimenopausal years. There's many causes for it. I've listed some of them here on the slide, such as perimenopause, diabetes, thyroids, anything that can disrupt the architecture of hormone building. Go ahead, next slide. The symptoms that you find with abnormal bleeding are spotting in between periods that last that come less than 28 days apart or more than 35 days apart, bleeding that is heavier than normal. This is important because that's actually a subjective finding. So as a patient, what defines heavy bleeding is simply what you interpret to be abnormal to your normal self, and bleeding for more than 7 days. These criteria make you a heavy bleeder, and you may want to seek help in order to identify ways to help your quality of life. Some of the techniques we use for abnormal bleeding is something called an endometrial ablation. An endometrial ablation is fascinating because it's quick, it's got almost no recovery, it uses no knives, and we circulate hot water for approximately 8 minutes, and with that we see an 80% reduction in bleeding and a nearly 70% in complete amenorrhea, which means no more bleeding. The only contraindication to an endometrial ablation is desiring further fertility. So this is a great option for somebody who doesn't want to go an extensive surgery but wants some resolution of symptoms when it comes to bleeding. A myomectomy is removing the fibroids by retaining the actual uterus within the body. The primary reason somebody elects to perform a myomectomy is for reproductive purposes. Most commonly performed in the age groups of childbearing. Usually the problem is that you see a recurrence of fibroids within 12 months at a rate of 50%. And a hysterectomy, there's many ways of doing hysterectomies. You can leave the ovaries behind, you can take the ovaries, you can take the fallopian tubes, you can leave them behind, and more importantly, you can take the cervix or leave that behind. These are all great questions and discussions to have with your physicians or with me at any time. Endometriosis is a condition that affects nearly 5 million people within the United States, and those conditions cause extreme pelvic pain and discomfort. Endometriosis causes actual implants within the endometrial cavity and the pelvic cavity. By using robotic surgery, we can identify these implants and resect them and really alleviate a lot of the pelvic discomfort that we find and therefore improve quality of life. So when we're speaking about hysterectomy, I wanted to just bring about all the different approaches so we can see how far we've come. Traditionally, until this day, open surgery is probably the most common way to operate in the United States and worldwide in order to remove a uterus or fibroids. That's where we're actually referring to making a pretty large incision in the lower part of the abdomen, and large enough for myself and other surgeons to reach in and manipulate the uterus and take it out in a safe manner. The problem with, or the downside to open surgery is that because there's a large incision, the recovery time takes longer. Usually requires 2 to 3 days of inter-hospital hospitalization, and the post-operative risk complication increases because you're not mobile, because you're more prone to infections, because you're more prone to herniations through the incision, and so there's a lot of varieties, there's a lot of reasons why if you can avoid open surgery, it's actually preferred. Traditional laparoscopy came probably in the 80s. The first laparoscopic hysterectomy was performed, I believe, in Northern California, and that was performed in 1997, which, if you actually think about it, is not that long ago. But laparoscopy in itself has come a long ways, our instrumentation has come a long ways, and laparoscopy is a really incredible stepping stone and the base and the foundation of minimally invasive surgery. That's where we actually make small incisions, and we decide the incisions, we decide where they are on the body geographically based upon the pathology that we have, the size of the uterus, and we use very thin instruments, including a camera, in order to visualize and manipulate our organs or perform a hysterectomy. The great thing about laparoscopy is that it decreases postoperative recovery time, it decreases the risk of postoperative complications, and allows the patient to return to daily activities much faster. But we've taken it even one step further in the last few years. I'll take the next slide, and that's robotic surgery. So robotic surgery is essentially laparoscopic surgery on steroids almost, because it's laparoscopic surgery, and at the very end of the instruments are articulating arms that mimic my own hand movements. And so to go back to open surgery, it's very easy to maneuver tissue and to do surgery when you're doing it in open, because you're using your own hands, as opposed to laparoscopy where you're using straight instruments. In robotic surgery, you're taking the advantage of laparoscopy and adding an additional factor, which is articulating arms so that it's almost as if I'm doing the surgery with my own hands. The other thing is that I'm not actually operating on the patient. I'm operating in a hood beside the patient, and the hood that I'm actually seeing is 3 and 4D. So the 3D vision that I'm seeing is much clearer than I can see with my own eyes. The incredible thing about the robot is not only does it mimic my hands, but it removes any tremors from my hands. So as I'm operating, it converts my hand movement into perfect flow movements, which for surgery, especially complex, delicate surgery, adds a huge advantage. Now, you're also able to see in a magnified fashion, and that's important when you're looking at very small structures that you really would have a much harder time with the naked eye or the laparoscopy. So when we're talking about endometriosis implants that affect a woman's quality of life because of pelvic pain, I want to be able to find as many of those implants as I possibly can. And by seeing magnification of the anatomy of the body, it allows me to identify and then cure the condition. Go ahead and move. So back to what I was going to talk about earlier, which is some of the conditions that are common and affecting women today are fibroids. Fibroids affect 20 to 25% of the general female population. There is a higher propensity in certain ethnic groups, as well as certain diets. But we see that fibroids are muscular tumors. For the majority of the cases, they're completely benign. And we'll talk about that there is a 0.07% incidence of a conversion to what is called a leiomyosarcoma, which is a cancerous form of fibroids, which has made some media hype recently. And I'd be happy to talk about that further at the end of the talk, but it's extremely rare. Fibroids range in size. They can be as small as an apple seed, but they can be as big as a grapefruit, and I've seen them as big as a watermelon. So imagine that sitting in your cavity. I did a surgery on a female patient a few weeks ago that had the uterus all the way up to her diaphragm, which for her quality of life she could barely function. Most fibroids grow in the uterine wall. These are the different areas that fibroids grow. We see that there's different locations. Depending on the location, we can tailor the treatment. We talked about earlier one of the treatments to do the circulating hot water treatment. That's very effective if the fibroid impedes upon this cavity. However, if the fibroid is in the middle of the uterine wall or on the outside, it's not accessible by the endometrial ablation technique and therefore not successful. So when a patient comes to see us, one of the first things we want to assess is where are the fibroids, how big are they? And we do that by doing some imaging studies, whether it's an ultrasound or an MRI, both fantastic imaging studies, but some sort of imaging study should be performed in order to really maximize the treatment options. So these benign growths cause many symptoms. They cause patients to bleed heavily. As I said, they're mass-occupying lesions, so they leave a sense of fullness in the abdomen. They cause enlargement of the abdomen, therefore not only uncomfortable, but aesthetically not pleasing as well, because you really feel bloated all the time. Because they press on organs, they cause major pressure symptoms, whether it's on your bladder by causing you to having to urinate more often, or on your colon, making defecation more difficult, or causing you other symptoms, even as lower back if it's pressing against your spine. They can also be present during pregnancy, and that's where we would see people getting treated for myomectomies prior to becoming pregnant in order to alleviate some of the complications associated with pregnancy and fibroids, as well as causing some reproductive issues. If you have a fibroid inside the uterus, it's so hard, their texture is solid as a golf ball, and so if they're going to compete for space with a baby, they're always going to win. And so you're always going to have adverse reactions when either trying to get pregnant or during the pregnancy. So again, I wanted to present that there isn't just a treatment for fibroids, there's multiple treatments for fibroids. There's medical treatments, so if the fibroids are small enough and the discomforts are not that severe, we may be able to get away with treatments, hormonal treatments for fibroids, such as placing a patient on birth control, or Lupron, which is an antagonist to estrogen, which is one of the building blocks for fibroids. Again, depending on the location, surgery may be a good option. Endometrial ablations, the circulating of hot water. There's some stuff out called uterine artery embolization or uterine fibroid, UFEs and UAEs. That's performed actually by a radiologist. That's where they identify the vessels that feed the fibroids and then insert microbeads to block off the vascularization and flow of blood to those fibroids, thereby allowing those fibroids to necrotize or die off on their own. There's a new modality coming on the market called focused ultrasound guided MRI, and that's using ultrasound technology to use a focused beam and using the MRI as sort of your topography, as your geography on how to exactly identify. But at the end of the day, the safest and least obstructive form is still robotic surgery. For fibroids in itself, in my opinion, robotic surgery is the most superior form of treatment for fibroids. The reason is I can get into places and maneuver the robot that I just simply can't do with traditional laparoscopy, and I'm still bypassing open surgery. Therefore, I'm increasing my recovery, and I'm increasing my empowerment for patients and decreasing my complication rates. Next slide. Another common condition that affects women is endometriosis. We hit upon it a little earlier. It affects a good number of women in the United States, 5 million. It's common during the reproductive age. Why? Because it's sensitive to hormones. So as you enter menopause and your hormones lessen, a lot of these fibroids, endometriosis, start to become inactive. The problem with endometriosis is not only does it cause a lot of pelvic pain, it causes a lot of scar tissue formation within the abdomen. And scar tissue is like super glue. It tends to bind things together, causing a lot of discomfort and a lot of referred pain in areas that you may not associate to be with your uterus, such as bladder, defecation. Go ahead, next slide. And some of the symptoms, as I sort of hit upon now, menstrual cramping, chronic pain in the lower back and pelvis, pain during or after sex, and that's because the vagina, the apex of the vagina, has now formed scar tissue, and it makes, when we're having intercourse, we're ricocheting the uterus and causing some sort of mobility, and that scar tissue is preventing that from happening, and it's reflecting sensory pains throughout the abdomen. Painful bowel movements, spotting or bleeding between periods, infertility again, fatigue. So you see that these array of symptoms affect women in a wide range of different ways. And so just because you have endometriosis, Mrs. X and Mrs. Y may have completely different symptomology. But our treatment is the same, which is using a robot to clearly identify where the implants are and try to remove as many of them to alleviate the pain and discomfort. Next slide. Another effect is pelvic organ prolapse. As we age or as we have children, we tend to lose the ligament support that naturally supports our pelvic organs in the abdominal cavity, and we start to find that these pelvic organs, the uterus, the cervix, the vagina, the bladder, start to slide into the vaginal canal and sometimes out of the vagina and are simply exposed, and that's called a procedentia. There are risk factors, pregnancies, which cause temporary distension and pulling on the ligaments, age, gravity, coughing through smoking especially, obesity, and a genetic predisposition. So some of the symptoms you may be feeling if your organs are prolapsing through your vagina, when you're sitting down you may feel a lot of pressure both in your rectum and in your vagina. You may again have painful intercourses. You may have problems again with bladder as far as urination is concerned. Lower back issues. The lower back is so close to all of our organs, it's oftentimes one of the main presenting symptoms. And just an overall discomfort. Go ahead, please. Next slide. And again, there's my treatment options. There's non-surgical. The number one thing you can do is lose weight. We see a 40% reduction in urinary stress incontinence, which is the inability to hold urine when you laugh or cough when you lose weight. By decreasing caffeine, especially in the evenings, you may be able to decrease the amount of times you're going to urinate during the nighttime. and surgical, which is the most effective form of treatment, is vaginal reconstructive surgery, urinary incontinence treatments, which we perform at Missy, which are outpatient procedures and extremely effective. And all of these help to restore the quality of life that these symptoms affect. So here we are. I wanted to show you guys what the different incisions look like. So the one large incision, which is the traditional way to operate, still performed today, and sometimes for good reasons, is that one large 10 centimeter incision on your lower abdomen. Then we move to traditional laparoscopy, where you see these tiny little incisions are made. They're about half a centimeter, and they're in multiple little areas, and that allows us to perform complex surgeries in a minimally invasive pattern, therefore again decreasing our recovery time and increasing our recovery time and decreasing our complication rates. The next slide is our robot. This is the traditional, when robotic surgery was first introduced and still used today, we use what's called multi-port. Still have to put multiple instruments in the abdomen in order to operate. Oftentimes it's the only and best way to operate if you have a fibroid that's very enlarged, if there's multiple things going on. But as I mentioned 2 weeks ago, we did the first single incision hysterectomy, and that was my incision, a 1.5 to 2 centimeter incision inside and hidden in the umbilicus, and with that I was able to perform the full hysterectomy. The advantages of that is that the patient got to go home and got to, when she recovers, which is rather quick, is able to feel empowered by going to the swimming pool and knowing she doesn't have any abdominal incisions. And I think that's going to be the new frontier that we're all going to try and challenge ourselves and able to provide women with these kind of relief. Go next. So I just wanted to show you guys, so this is how the robot works. Here's the robot. Here's traditional laparoscopy, where you see we're standing above the body. We're using these long instruments, and it's good, but our maneuvers are limited, and we're looking on a television screen in order to operate. Well, here's the robot. We've docked the robot to the actual body of the patient. Once it's safely docked, there's still a surgeon on the patient, my assistant. And I scrub out of the case, and I actually walk over to a little console where there's pedals, and there are something similar to what's called a joystick, and it exactly replicates and emulates all of my movements, and also removes any of my hand tremors. And I'm able to see through that screen what the robot sees, which is in HD and in 3D. So it makes it amazing. This is actually my patient that I did 2 weeks ago. This was immediately post-operatively. I did a full hysterectomy on her abdomen, and it looks amazing. There's not a single scar to be seen. And this is in the operating room. Here's my scar right in here, and this is what it looked like right after I operated on her. Almost no blood loss. The reason is because we have excellent control of the situation. I can see very clearly. I have my surgical assistant with me on the table if I need anything, and with the robot I can move quickly, and it emulates my exact movements. So we find very low rates of complications and very low blood loss. My actual conversion rate to this day, knock on wood, is 0%, but I would say overall for everybody it's extremely low. So when we start out doing robotic surgery, and our intentions are to do robotic surgery, it's very rare that we will have to actually convert to what's called an open incision because the surgery is too complicated. Go ahead, next. With every surgery, as great as the benefits are, you always have to explain and make sure that the patient understands that surgery, although safe and very rare, we may encounter some complications. Given the area that we operate in, we're constantly surrounded by the intestines and bowel. And so there's always a possibility for bowel injury. Now, we're very careful and we use very specific maneuvers in order to minimize that, but that is a possible complication. We may injure the bladder, especially if there's endometriosis and scar tissue around the bladder. One of the things that myself and my colleagues often do is put a camera in your bladder after we operate called a cystoscopy, and that allows us to visualize any sort of complication that might have occurred with the bladder that can be fixed immediately intraoperatively. See, the whole thing with complication is not so much that the severity of the complication, is you want your surgeons to be able to identify the complications right then and there. Because if we can identify the complications right then and there, we can fix it. And by fixing it, most of the time we can resolve any further complications from it. Next slide, please. That's really my presentation. I hope that you guys will ask me some questions because I hope you found it interesting. But I wanted to present my surgical options. Whether or not you're a candidate for virtual scarless hysterectomies, I'd love to talk about that. You do want to find a physician that does have experience with it. There is a learning curve with it. And you always want to ask your physician what are the risks and benefits, and make sure they take the time to explain not only how great the procedure is, but what possible outcomes can happen from that procedure. And then what's the recovery like? And next slide, please. And with that, I'd like to thank you guys for coming and listening to me. I hope it wasn't too medical. I hope I made it clear and precise. And thank you very much. And thank you, Marina Del Rey Hospital and Missy. Any questions? Yes, Mark.
Dr. Goslin, what's the training like for the Da Vinci robot? How long does that take to get trained?
So, before you can become a robotic trained physician, you have to be an advanced laparoscopic surgeon. So you have to have gone through all the necessary steps to really push the envelope, because with each technology, you have to have mastered the technology prior. So once you've done that, then the Da Vinci Institute, or Intuitive, is actually pretty selective in who they decide is going to be able to use this technology. One, they're protecting themselves and the robot and their view in the media. And second, they want to make sure that the patients that are being handled by surgeons that are very capable. Once that decision is made, we actually get flown to an actual cadaver lab or a pig lab where we actually practice for quite some time using different techniques and the robot. And then once we return to our home base, we actually have to perform the procedure with proctors in order to feel more comfortable doing it. Once that's done, then we're able to perform it on our own. So I've been doing this now for 2 years, and about 3 months ago I was asked to become a pilot program, part of a pilot program in using single incision hysterectomies, which is really not available just yet. Very few selected surgeons are capable of doing it at this time. But I think it's going to be available come the fall, and I think it's going to make a huge difference in being able to provide single incision hysterectomies. Part of having great technology is also understanding which patient is good for that technology. So single incision hysterectomy is obviously in its infancy right now. So we're very selective on who is a candidate for a single incision hysterectomy. You have to meet certain criteria such as size of the uterus or size of the ovaries. Because it's new and because the movements are slightly restricted, I'm introducing all these instruments through a 1.5 centimeter incision. I have to be certain, and that's why I rely heavily on MRIs and ultrasounds in order to distinguish who's a good candidate. Once I have freed up the uterus, how do I take out a uterus that's the size of a grapefruit out of a 1 centimeter incision? And what we do is we actually bring the uterus to my little incision, and using a special instrument called a morcellator, we're able to take out the uterus in small little pieces, and those little pieces get sent off to pathology. And so that's how we're able to take out large masses through a tiny, tiny incision.
How do those little pieces stay intact and not, get dropped into the area where your intestines are?
Great question.
Our
So,
abdomen.
So that's a very good question, because sometimes it does happen that you may leave behind a little piece of fibroid. So as minimally invasive surgeons, one of all my tasks as I'm doing this is to be extremely diligent and almost to the point of obsessive in making sure that all my little pieces have been removed. The great thing about it is the body's not moving. So even though there's intestines there, it all stays on the surface because the patient's nearly paralyzed. And so I can find and see all my little pieces, and we just pick them up and take them out one by one. Should they stay in, what happens? Well, there is a risk of parasitic myomas, which is a risk that somehow a fibroid will form in your abdominal cavity, even though the risk is extremely small. And I don't know that there's even enough data to quantify an exact percentage on that. The bigger question is, what if the uterus I'm taking out actually has cancerous cells and I'm taking it out into little pieces? Well, again, you want to make sure that when you pick your surgeon, that they've done the appropriate workup in order to minimize any of those risks. Look, whether you're doing surgery for fibroids open or via a robot, you're going to disseminate cells from that cancer in your abdomen no matter what. What you want to minimize is leaving any pieces behind or identifying the fact that this is what's happened. If that's the case, the next step is to immediately consult a GYN oncologist who will then further the surgery and do what's called staging in order to figure out where and how advanced the cancer is. But one of the criteria that I use is a good history, ultrasound. I like the MRI with contrast as a diagnostic tool. Sometimes we have to battle insurances to get that done, but if we can, that gives us a lot of good data on how big the fibroids are, what they are, and what they look like. Are they calcified? Are they taking up the contrast effectively? These are all good little indicators. There's a new study out of Japan called the GOTTO study, GOTTO, that uses an isoenzyme called LDH to identify or help to identify the incidence of falsely positive leiomyosarcomas. That's way too in-depth and it's not really utilized in the United States. At the end of the day, it's about patient selection, proper screening, and then having confidence in your surgeon. If anything looks abnormal, us as surgeons can always do what's called a frozen section intraoperatively and right away identify if there are cancerous cells present. Do we do that on every patient? No, because the incidence of cancer is 0.07%. So in an entire career of doing fibroids, I may see one case. But those cases usually, I hope I'll see never. But as long as you identify it quickly, are you really doing harm to the patient? Because it's always about, are you doing harm to the patient? By quickly identifying the studies they've done so far at tertiary centers, which are higher volume cancer centers, have shown that whether you stage cancer immediately or within a very, very short time difference, the long-term outcome for survival isn't much different. Besides that, a leiomyosarcoma survival rate is extremely low at 5 years. So have you really changed the outcome for the patient? Probably not. But by doing this, you've really changed the quality of life for the majority of patients by providing these kinds of surgeries. Yes?
Dr. Gaza, you mentioned that post a myomectomy, the recurrence rate of fibroids is within 12 months is about 50%. Why is that?
Well, there's a few reasons why. First of all, fibroids have a genetic predisposition to them. So if you're prone to form fibroids, there's a good chance that you will form them again, whether I take them out. By doing a myomectomy, you're not curing the patient. You're treating the exact symptoms and putting a Band-Aid on the patient. The number one reason to perform a myomectomy in the United States is purely for fertility reasons. So if a patient came to me and said, Dr. Gaza, I have these fibroids, I can't get pregnant, or I'm desiring pregnancy, that's a great candidate for a myomectomy. If somebody's coming to me who's in her late 40s, early 50s, and has abnormal bleeding or pelvic pain with fibroids, I wouldn't recommend a hysterectomy at that point. I would not recommend a myomectomy. I would recommend a hysterectomy. Now, at the end of the day, these are all my opinions. The patient is really the number one decision maker in this process. I like to guide the patient in helping what I think is the best decision. But for a lot of reasons, some people want to retain their uterus and feel that they need to do so. And in those cases, what we can hope for is that we take out the fibroids and we gain enough time that their estrogen levels decrease and the recurrence of fibroids will be minimal. Yes?
Hi. To further Violetta's question, I actually had a myomectomy last September. I'm not a medical professional, I'm a normal person. I had a myomectomy in September, and fibroid was the size of a grapefruit. I am 53. I just was one of those people that did not want, I just wasn't ready to have a hysterectomy. Wasn't what I wanted to do. I was not a candidate for the embolization where they put the dye in for some reason. So I had the myomectomy. Now here we are in May, and by February of this year I have 2 new fibroids. So as far as the robot that you're using, is there any advantage to people that have recurring fibroids? I guess my question is say I wanted to have the new fibroids removed. I mean, is there any advantages to the robot procedure since it's so minimally invasive that it would be something that you would use to retreat and remove and?
Are you on hormone therapy now?
No, I'm a heavy smoker.
And did you have an open hysterectomy?
No,
I mean
I
an open myomectomy.
Yes.
They open you up.
Yes, the first picture I had
Right. So you have the open incision. So
yes.
one of the problems with open incisions is that we find that the more you manipulate tissue, the more scar tissue develops. So what we always worry about in these kinds of cases is once you've been open, you might have developed some extra scar tissue. The advantage to doing robotic surgery is that when I go in and I come out, I'm hopefully minimizing the amount of scar tissue that I'm going to leave behind. Now, scar tissue forms in everybody differently. It's the way your body responds to stress. It's the way that the body responds to injury. It doesn't know you had surgery. It knows you got hurt. So the answer is, in order to decrease your recovery period, decrease your complication rates, I would suggest doing a robotic hysterectomy. In your case, I would be very careful in making sure that your workup included an MRI, because you are in your early 50s with recurrent fibroids. The chances of them being benign are extremely good, but you'd always want to make sure that we're not dealing with a situation with fast-growing fibroids that could, that it's a cancer that's mimicking a fibroid. And so in your particular case, your preoperative workup needs to be very, very pristine in order to see. Or else I would suggest that you do a hysterectomy, even though I know that you're anti-hysterectomy.
I think I'm just more afraid of the hormone.
So that's a
coming
great
into
question.
play
I think I could ask
immediately,
this-
and I think that made me a little fearful.
I'm going to interrupt you because I think you brought up an excellent point that was not mentioned that I get asked frequently. Dr. Goslin, I'm afraid of a hysterectomy because I'm not ready to go through menopause yet, and I want my hormones. And the answer is, by doing a hysterectomy and leaving the ovaries behind, you're actually not going through menopause. The only thing the only reason you have a uterus is to make your periods and have a baby. Its hormone production is non-existent. So I will agree with you that some studies have shown maybe a decrease in the amount of hormone production once a uterus is removed. But you still have enough hormone production in your ovaries to sustain yourself and not go through menopausal symptoms that would affect your quality of life. What I would recommend, some of the latest data today is showing leave your ovaries behind, but make sure you take your fallopian tubes along with your uterus, because epithelial ovarian cancers can come and originate primarily from fallopian tubes. And that's something that I've recently started doing, and I know a lot of us are starting to do. So the answer is, there's a big fear factor about this is going to change me as a person by removing my uterus. And look, I understand you're removing a part of you that's gone forever. And there's a certain amount of attachment that you feel to your own self. As far as hormonal production, as far as am I really going to feel differently by removing my uterus and keeping my ovaries behind, the answer overwhelmingly is the same. You're going to feel just as you are now, without having the complications of a fibroid, without taking any of the risk factors associated with the conversion of a fibroid to a leiomyosarcoma down the road.
I actually wasn't so attached to my uterus, but definitely attached to my
Ovaries.
mental health, I guess you could say. I mean, with if they were going, if it was a full hysterectomy, I kind of felt like I'd be slammed against a wall right into menopause, and that scared me. So I wanted to ask you another question. One of your the PowerPoint presentation said something about thyroid. Does that thyroid come into play? I have hypothyroidism. Does that come into play?
So great question. Hormones, we like to look at it as a symphony, an orchestra, produced by many different organs, both your hypothalamus, your pituitary gland, your thyroid glands, your ovarian production of testosterone and estrogen. They all have to work unanimously and in sync. So if your thyroid is off, it throws the whole entire symphony off. And so one of the things that we always want to look at is actually evaluating somebody's entire hormone panel, looking at all the different reproductive hormones produced by a woman, but also looking at your thyroid gland, which is very important in deciding how you feel, energy-wise, metabolism, but also whether or not your periods are going to be normal. So definitely have it checked out. Yes.
What is the recovery period for myomectomy versus a full hysterectomy using a robotic procedure?
So, good question, and again, very different in everybody. I've actually had patients, and I've actually videotaped their testimonials, and I think it's actually available on the Marina Del Rey website. Am I correct, Nick? Yes. Where I've actually done a robotic hysterectomy. They've gone home within hours of the surgery, and I've actually walked their dog that same evening. I mean, think about how amazing that is, because traditionally we do open surgery on hysterectomies, and patients can't even eat for 24 hours. They can't even get out of bed for 24 hours. They're completely drugged up with IV narcotics. Where here we have patients walking their dogs post a major surgery through robotic surgery. Now, everybody's different. I've had patients who a week out are still in discomfort, but they were never hospitalized. They never took on the risks of post-operative complications. Whether it's a difference between myomectomy versus full hysterectomy, believe it or not, it is actually easier for me to perform a hysterectomy, and we have some GYN surgeons here in the room, than it is to perform a myomectomy. Because with the myomectomy, I have to shell out those fibroids, which are very vascular. One of the treatments we said earlier was uterine artery embolization, using beads to insert into the vessels. These are very vascular tumors. And so they have a tendency to bleed. We have to sew them. We have to sew the tissue back together in your abdomen. And then, there's a lot more manipulation of tissue. With a hysterectomy, I find the ligaments that the uterus are attached to. I find the vasculature that it's attached to. I coagulate it and cut it and remove it out. So it's a much faster, easier process, even though it sounds more aggressive.
Is it still I'm not a doctor, but
Yeah.
is it still like a slice and dice kind of thing where you have to reduce tissue into small little pieces to extract it, which you're going through Schmelling method? Or are you using, when you're doing the hysterectomy,
So-
are you using other?
So there's, I said there's different types of morcellations. Morcellations is the ability to remove tissue in little pieces from a big mass. There's three ways of doing so. You can remove it vaginally. So let's say we do a full hysterectomy and take out the cervix. I can actually pull the uterus, the cervix out through the vagina, and then simply close off the vagina at the apex. By doing that, there's no morcellating whatsoever. It's simply sliding the specimen out. Or morcellating within the vaginal cavity and not in the abdominal cavity. The advantage of that is there's no morcellation. If you have abnormal cervical pap smears, this will take care of that issue as well. The disadvantage of that is that you lose some of the ligament support from your cervix and the vagina. The second type of morcellation is by bringing the specimen to the actual incision site. Believe it or not, using the single incision, the incisions are slightly bigger than the traditional robotic incisions, which are 0.5 centimeter. This is 1.5 centimeters. So in the case I did here at the Marina, we left the cervix in, because I always think it's a good idea. as long as there's always been abnormal pap smears. And without power morcellation, I took the uterus out of the incision and just rotated my scalpel around it and cored it like an apple until it came out. The advantage of doing that is you're not leaving anything behind in the abdomen, for sure. Well, I mean, there's never for sure, but the risks of that are less. Sometimes you can't do that when the uterus is really big, the size of a grapefruit or a small watermelon. You have to take it apart within the cavity in order to extrapolate it out of the body. So those are the different types. Any other questions, you guys? Well, I want to thank everybody. Great questions. Thanks for participating. Make this an active engagement of discussion. And hopefully I can be of assistance and talk to you guys further. And hopefully you've learned something. Thank you very much.